Hi, good morning everyone. So my topic of discussion today is conjunctival tumors, an overview of the melanotic lesions. You have seen a beautiful presentation on the non-melanotic lesions, which Dr. Vikas Menon took you through. I have no financial disclosures and these are my affiliations. So I have put these pictures in place here, A to F. So I want the response from the audience. Which one do you think is malignant among this? A? Not really? No. Sonal says no. B? No. C? Possible? Possible. D? Definitely possible. E? Sure? 100%? All right. And F? No? Plus or minus. All right, perfect. So we'll go through this in the next 15 minutes. So melanocytic lesions, again, is classified into benign and malignant. And why is it so important? Because the malignant variety of the melanocytic conjunctival tumor is life-threatening. It's lethal. Conjunctival melanoma, which we will be going through in subsequent slides. So the benign lesions are conjunctival nevi, racial melanosis, congenital ocular melanosis, and primary acquired melanosis. So this is a 50-year-old patient who presents with this pigmentation in one eye. Do you think it's benign, malignant, or do you want to give me a diagnosis on this? Yes, Sonal? Sonal says complexion-associated melanosis. Yes, sir. Same, yes. So it is complexion-associated melanosis, especially in brown-skinned people like us from India and Africa. We have this kind of pigmentation, similar pigmentation that happens in the skin. The similar pigmentation happens in the conjunctiva too. So this is a complexion-associated melanosis. And it does give a variable pigmentation. It has to be differentiated from other melanocytic lesions. It's usually perilimbal, bulbar conjunctiva, and the cornea which is involved. And it's very uncommon to find these pigmentation in the fornix and the palpebral conjunctiva. Mostly it's in the sun-exposed areas. So this is yet another case. All right, so this is a 45-year-old gentleman. This is the left eye of the patient. This does have complexion-associated melanosis, right? Yes? So there is pigmentation around the limbus. There is scattered pigmentation over the bulbar conjunctiva. I'm going to show you the other eye, all right? So this is the right eye of the same patient. Can complexion-associated melanosis be asymmetrical? Can one eye be more pigmented and the other eye be less pigmented? It do happens? Quite unlikely. So whenever we find this much of an asymmetry, you see how much darkly pigmented the conjunctiva is. It's very asymmetric, very, very asymmetric. So whenever there is an asymmetry in complexion-associated melanomas, melanocytosis, something that you really need to think about is a primary acquired melanosis, which usually presents unilaterally. And these deep pigmented primary acquired melanosis is again a matter of worry. All right, so biopsy was done, and this is what it came out to be. So it came out to be a primary acquired melanosis with atypia, which has a high chance of progressing into conjunctival melanoma. So this was asymmetric pigmentation, again, in a patient who had complexion-associated melanosis. One eye progressed as primary acquired melanosis, and that too with atypia. Very easy go. A pigmented lesion, there is a feeder vessel over here, little bit of intrinsic vascularity here in a young patient in the bulbar conjunctiva. Conjunctival nevus. And what is the most characteristic feature that you see here differentiating this from other melanotic lesion in the conjunctival nevus? The cystic spaces, yeah. Absolutely. So you see this microcyst and the macrocyst in a pigmented lesion in the conjunctiva that is very characteristic of conjunctival nevus. All right. So this is a case of a conjunctival nevus. So whenever we talk about these lesions in the conjunctiva, be it in the lid, anywhere, whenever we find a feeder vessel, it's again alarming. You know, a feeder vessel, we always correlate it to Dr. Vikas had shown you many amelanotic lesions with large, thick feeder vessels. So even conjunctival nevus can have feeder vessels, because these conjunctival nevus, most of the time, the parents comes to your clinic telling, well, I'm seeing this lesion growing in my child and I'm worried. So these are the vessels which actually leads to the growth of these conjunctival nevus. And it does has growth spurts with the growth spurt of a child when there is again hormonal changes in the body. So even 64% of the conjunctival nevus can have feeder vessels, but you need to look at the other characteristic features like microcysts, macrocysts, variable pigmentation, lighter shade of pigmentation, and not darker shade of pigmentation. Can it be, usually it appears unilateral, but can it be bilateral? Conjunctival nevus. How many of you have seen bilateral conjunctival nevus? Yes, sir. Anyone else? Yes. So conjunctival nevus can be bilateral again. So this was a lady who was 36-year-old who presented with this lesion in both the eyes. As you can see here, the right eye, there is pigmented, slightly amelanotic lesion here. And then you can see large cystic lesion in the left eye also. Closer look of it. So she has a melanotic component of a nevus in the right eye as well as the left eye. So nevus can be slightly amelanotic and melanotic also. The presence of cyst and these feeder vessels gives away the diagnosis. Yet another very important diagnostic tool in differentiating whenever you are like kind of suspicious of this conjunctival nevus being a melanoma, when it's especially when it is amelanotic, is the anterior segment optical coherence tomography. As you can see here, you will see the evidence of the microcyst and the macrocyst in these lesions. So this was a young patient who presented with bilateral pigmentation in the eye. As you can see here, milder pigmentation in the right eye and diffuse pigmentation in the left eye. A very interesting case that I saw during my fellowship with Dr. Honavar. Very interesting case. Do you think it's malignant? Very diffuse pigmentation. The entire conjunctiva is covered almost, except the temporal small part. Well, it's darkly pigmented. You don't see any vessels here, right? Don't you? There is no feeder vessels. There is no intrinsic vessels. Well, there are not too much of cysts also, but you can see this bulginess over here. It is like, you know, it's wavy, it is elevated at certain position, it's kind of nodular at certain position, but not, and it freely moves over the conjunctiva. It doesn't have attachment over the tenons. So, well, it's more of a benign lesion. So we went ahead doing a biopsy, and this is what we found. It was a nevus, but it was a giant balloon cystic nevus, which is a very rare variant of a nevus, diffusely presenting like this over the surface of the conjunctiva. Yet another case, a young man presenting with this pigmented lesion on the conjunctiva, very minute pigmentation in the bulbar conjunctiva. It doesn't look like racial melanosis, right? It doesn't. It's slightly darker pigmented, right? PAM, primary acquired melanosis? No. What else? Nevus? Not really? Okay. Foreign body. So this person was working in a mine, and he came with an injury where there was a mine blast, and well, these foreign body can just get trapped in the tenons and the sclera, presenting as melanocytic lesions of the conjunctiva. So you have to look around for the evidence. So he had all these foreign body which has been embedded in the upper eyelid too. So this is a case of very faint pigmentation of the bulbar conjunctiva. I'm sure all of you know the diagnosis here. Unilateral presentation in an old patient. PAM, yes, primary acquired melanosis. So usually primary acquired melanosis is found to be unilateral in middle-aged patients, and it affects the bulbar conjunctiva. It usually has this cobblestone appearance over here, microfolds. Again, it is variegated, and they will be absent of feeder vessels. Now, PAM is very important, especially in the Caucasian population. So the extent of the PAM, from the extent of the PAM, we can actually decide whether it could be, there could be a possibility of this PAM turning into a melanoma. So you all know that 75% of melanoma arises from primary acquired melanosis. It's so very important to identify the dangerous PAMs. So this is the algorithm, and which was suggested by Dr. Shields and Shields from the Wills Oncology. So they have found that depending upon the presence of claw cover of involvement of PAN, there is a high risk of these lesions turning into conjunctival melanoma. Again, these are the abnormal locations of the PAM. Usually we see PAM in the bulbar conjunctiva. So whenever you see this variegated, diffuse, pigmented lesions somewhere in the tarsal conjunctiva, the phonacial conjunctiva, in the caruncle, then it's again alarming. So these could be those PAM which is turning into a conjunctival melanoma, which really requires a biopsy to prove that it's not conjunctival melanoma. So a PAM without atypia, the progression to melanoma is 0%, whereas PAM with atypia, and if it's severe, the progression to conjunctival melanoma is 32% according to the AF5P study. So it's really important to identify these and do a biopsy to make sure that the PAM is not harboring a conjunctival melanoma. Going on to conjunctival melanoma, which is a very important topic here, because as I told you, conjunctival melanoma is life-threatening. If it's not detected early, if it's not clinically diagnosed and managed appropriately, the patient can die due to conjunctival melanoma. It's usually found in the Caucasians. We do see it in India also. Unilateral, elevated, it can be fleshy. It can be both melanotic, even amelanotic. As you can see here, it's an amelanotic conjunctival melanoma. What you need to look for, as in any other malignant lesion, is the nodularity, the thickness, the color of the lesion. As you saw in the conjunctival nevus, it was more of a lighter shade of brownish pigmentation, whereas in melanoma, it's much darker pigmentation. So when a lesion turns more darker, more nodular, more elevated, with this fleshy appearance and a thick, large feeder vessels, then it can be a conjunctival melanoma. So these are the characteristic clinical features of conjunctival melanoma. There are systemic association. Whenever you suspect a conjunctival melanoma in a patient, you need to ask the patient whether you have any other pigmented lesions in other parts of the body in order to rule out dysplastic nevus syndrome. Again, neurofibromatosis can be associated with conjunctival melanoma and xeroderma pigmentosum. So this is an amelanotic variant of a conjunctival melanoma which is present. But yes, again, there will be some clue over this amelanotic lesion also. So there, as you can see here, this is the one arising from a PAM, and you can see the pigmented portion of this melanoma over here with thick nodularity, lots of feeder vessels, and these are the intrinsic vessels. I'm going to share an interesting case over here. So this is a 28-year-old male who presented recently, less than a year, with me, who was referred for bilateral pigmented lesion and a suspected nodular lesion in the right eye. So this is how his right eye appeared like. All right, so there is a large nodule sitting in here. On clinical examination, so this was immobile using a cotton bud tip. So that means there is some amount of scleral infiltration. So there is a lot of thickening all over here around the lesion, feeder vessels, intrinsic vessels, and yet another pigmented lesion over here, a lot of pigmentation over here. And this is how we document. So every patient coming with any conjunctival lesion, be it melanotic or amelanotic, documentation is so very important. You need to know what are these lesions which is existing and coexisting in the conjunctiva of the patient. So what we found was, which caught our eye, was the main lesion, which was very nodular, and clinically we suspected it to be a conjunctival melanoma. There was this pigmented lesion over here. Well, he had diffuse pigmentation. It could be the lesion, a conjunctival PAM, primary acquired melanosis over here arising, and then he had pigmentation over here. So we were worried about these three lesions in this patient, and the plan was to basically excise this with my wide margins, which Dr. Hunava will be taking you through, and then excise this portion in order to rule out whether it has any atypical features, and then cryo this area. So ultrasound biomicroscopy was done in order to know intraocular extension and scleral invasion well, and there was some amount of superficial scleral invasion in the nodular portion. So it's very important whenever you find in your clinic, you use a cotton bud tip and the lesion is not moving, it is mandatory to do an ultrasound biomicroscopy to rule out scleral invasion. So this patient had a scleral component. So this is the left eye of the patient with diffuse pigmentation again. So we did go for the excision with a wide margin of this lesion, and cryotherapy to the other eyes. So this is actually after 2 weeks of cryotherapy to the left eye, where you can see all the pigments has clumped, which was an acquired melanosis in the left eye. And unfortunately, this came as melanoma as expected. Even a superficial sclerectomy was conducted in this patient where the sclera came negative, the base was negative, and surprisingly, this was also a melanoma. I never thought that that could turn out to be a melanoma. I thought it would be something with atypia, but it turned out to be a melanoma. And I had to take him again for excision with complete margin for that small tiny lesion later. So this is after complete management of the right eye and the cryotherapy of the left eye, where the pigment has kind of reduced in the left eye too. So 75% of conjunctival melanoma arises from primary acquired melanosis, 20% de novo, and 5% can arise from the conjunctival nevus. Yet another interesting case, as you can see here, a patient with a conjunctival nevus is a young child who was lost to follow-up and then developed a conjunctival melanoma. You can see this fleshy area with hemorrhages, lots of vascularity, and this is the anterior segment ocular coherence tomography and ultrasound biomicroscopy, where you can see there is cyst in one portion which is correlating to this area, and this has become thickened. So there is, you can see a transformation from a conjunctival nevus to a conjunctival melanoma in this case, which is correlated with this pathological picture over here. The cystic area, which was the conjunctival nevus, right from here, it has turned into conjunctival melanoma. So it's very, very important to keep these patients under strict follow-up. Even if they have a conjunctival nevus, it can turn into a conjunctival melanoma later, and you have to talk that to the patient. So why is conjunctival melanoma so important? Because it is reported that 20 to 40% can have regional metastasis. 9 to 25% can have systemic metastasis. So these are the typical features which indicates that there can be high risk of systemic metastasis and regional metastasis in conjunctival melanoma. Anything more than 2 millimeters in thickness, larger basal diameter, nodular lesion, non-limbal location, margin positivity once you excise it surgically, orbital extension, and de novo origin. Mortality in conjunctival melanoma, what do you think it is? 5%, 6%, 10%? Okay, so at 5 years, it's reported as 16%. At 15 years, the mortality from conjunctival melanoma is 32%. So we cannot take it lightly. Any patient with conjunctival melanoma has to be diagnosed appropriately and managed appropriately, which Dr. Hunava will be taking you through in the management. So again, Dr. Vikas showed you the AJCC classification of OSSN. Conjunctival melanoma is also classified under AJCC. So it's very easy to remember, not tough in fact. T1, anything in the bulbar conjunctiva. Again, you have A, B, C in that, depending upon the quadrants. T2, anything other than the bulbar conjunctiva, palpebral, phonacial, and the caruncle. That is T2. Easy to remember, right? T3, anything with local invasion. It could be globe, it could be eyelid, it could be orbit, or the paranasal sinus. And of course, T4 is with the intracranial invasion. So this, we usually use it in our practice, and we do stage in the AJCC classification. And this has been reported by Dr. Shields that melanoma classified as T2 and T3 showed significantly higher rates of local recurrence, regional lymph node metastasis, distant metastasis, and death. So anything, any lesion which is present in the caruncle, in the phonesis, it's very important to image them radiologically, either with a CT scan or an MRI, in order to look for orbital extension. So the management is entirely different if a conjunctival melanoma is extending into the orbit, and that would be exenteration? Well, there are many other targeted therapies which has come up in order to reduce extensive conjunctival melanomas also. I'm sure sir is touching upon that. Yet another thing which we all consider is the sentinel lymph node biopsy in order to know whether there is any regional metastasis when the patient has presented with conjunctival melanoma. So sentinel lymph node biopsy is basically tracing the radioisotope which has been injected in the conjunctival cul-de-sac with lymphoscintigraphy and a gamma probe which is like placed on the regional lymph node, especially the preauricular lymph node. If it is positive, it is dissected and a radiotherapy is performed for the regional lymph node metastasis, and further metastasis doesn't happen. Why is it important? By Kivela et al., they have found that anything more than 2 millimeters in thickness, the regional metastasis has been reported to be 18% and systemic metastasis to be 30%. So it becomes mandatory for those lesions who has more than 2 millimeters in thickness to undergo sentinel lymph node biopsy. And these are certain papers which have spoken about the same. Well, just a quick trivia question here. I showed this in the first slide and someone said, yes, this is malignant. So this is conjunctival melanoma? I did not ask you, sir. Please don't give away the answer. You know it. Anyone from the audience, did you see what hear what he said? No. Yes. So this is an OSSN. And why do you think it's OSSN? No, please. Why do you think it's an OSSN? Sir, please, no. Sir, bolo, sir. कैसे, sir? Intuition कैसे? Feature बताओ. What makes you think? Sir, ऐसे थोड़ी होते हैं. Why do you think it's an OSSN and not a melanoma here? Yes, sir. Please go ahead. आप बताइए. Elevated है, feeder vessel है, तो malignant हो गया. लेकिन melanoma क्यों नहीं? Keratin hai, absolutely. So although it is like majority of the lesion is pigmented, but you can see this traces of keratin, this whitish deposits on the surface. So this is a pigmented OSSN. Well, you have to again differentiate a pigmented OSSN from a melanoma because we take melanoma much more seriously when compared to OSSN. All right? This one, this was also there in the picture. Someone said, well, nevus? Yes, so this is a nevus over here. Anything other abnormal? Is there any other pigmentation in this eye? Iris, yes. So do you think, and here, it's extending here, and then there is a pigmentation over here. Any other possibility that you can think of? Ciliary body melanoma, yes. Okay, a ciliary body melanoma extending into the iris with an extraocular extension. So you have to do an indirect ophthalmoscopy in all these patients, again, who presents with a pigmentation in the conjunctiva. Thank you very much. So pigmented lesions, again, presents with a wide clinical spectrum. Accurate clinical diagnosis is very, very essential in order to plan the management. And I'm sure sir is going to take you through an excellent presentation on the management of these lesions. Thank you so much for your patient listening.